Good morning. We're going to get started so we can stay on time. My name is Sievenpiper. I'm from the University of Toronto. I co-chair Raben from Copenhagen. This is Section 7, Nutrition Support for Diabetes in Hospital. The DNSG-ESPEN joint session. We're pretty excited to have that. Thanks to our second speaker, Raben. This very special session to bring to you the joint session. We hope to then. Just a housekeeping note that Paul and Jordan wanted you to know on the back table, the back corner, are all the certificates for delegates, for oral presenters, long oral presenters, and invited speaker for your presentation, and delegates as well. So if you want to pick up your certificate, it's about. So with that, we'll introduce our first speaker, Dr. Mechanick. From Mount Sinai, New York. He's going to talk about the impact of medical nutrition therapy to diabetes and the inpatient setting.
Great, thank you, John. Everybody can hear me? Good, and thank you. It's a pleasure to be here again this year. It's my favorite conference, something you're going to be hearing all the speakers say, I think. It's not working. Now is it working? The old on-off switch trick. Okay. So I'm going to be speaking on medical nutrition therapy for diabetes, but in the inpatient setting. And actually, while I was trying to prepare for this, one of the things I was impressed with is actually that there wasn't so much data and evidence. I thought I was just going to be going through a lot of information, and I was rather surprised how little there was. These are my disclosures. What we're going to do is we're going to start off with some context, and instead of just saying type 2 diabetes or diabetes, we're going to put it in a framework, this new framework of dysglycemia-based chronic disease. This has actually been something I've been working on for the last 8 years or so, reframing these chronic diseases in terms of complexity, and the evolution over time. And you say, well, why do we need to remodel this? And that's because the paradigm of healthcare is really changing. We're not just waiting and waiting and waiting for people to get sick, and then we intervene. A lot of costs, a lot of side effects. We're not that great at it. Rather, we want to expose opportunities for early and sustainable preventive care. And the preventive care gets codified in terms of primordial, primary, secondary, tertiary, and quaternary, the prevention of over-medicalization. So I'll show you this model. We're then going to go right into lifestyle medicine and then build this narrative, where as a component of lifestyle medicine, and yes, we can apply this in the inpatient setting, that component is nutrition. We'll talk about inpatient medical nutrition therapy, go through what I thought as I curated the evidence, what would be some of the more interesting aspects in the inpatient setting, and then we'll have some conclusions. So the premise with dysglycemia-based chronic disease is that the current definition of, let's say, prediabetes really needs to be considered not in isolation. If you consider prediabetes in isolation, you're going to end up with saying it's not cost effective to intervene, that there's this implicit assumption that you're going to be throwing medications on board, which are costly, and the number of lives saved with all of the statistics involved just isn't going to do it. And Montori wrote some great articles about this. And that prompted us at ACE, going back quite a number of years, to say, you know what? Let's not look at it in isolation. Let's look at the whole spectrum of dysglycemia. And you're going to see where it's not just dysglycemia, but we're going to link it to abnormal adiposity and dysglycemia and hypertension and a whole cardiometabolic framework. So here it is. To the left, you can see the original paper in Endocrine Practice, and there are 4 stages. Stage 1 is risk, and that's insulin resistance. Really the dominant driver that's in this network of players for these chronic cardiometabolic diseases. Second, stage 2 is pre-diabetes, You have a beta cell defect now, but that beta cell defect just isn't strong enough to hit these arbitrary human-made thresholds, A1C is 6.5, fasting sugar 126, et cetera. It falls short, but it's abnormal. It's abnormal, and prediabetes really is the same. It's fitting in this spectrum. It's not something different. It doesn't mean you don't have disease or you're healthy and you're just at risk of developing type 2 diabetes. In fact, there was a study that the risk of going from prediabetes to cardiovascular disease was greater than the risk of just going to type 2 diabetes. That's the impact of prediabetes. So we built this model, and through a consortium of investigators globally, we looked at different registries to validate the model. Here's some data on the right from a registry, the CardioViews registry in the Czech Republic, looking at how this model behaves. First of all, you're catching a lot more players, a lot more patients at risk with this model, rather than classifying them only as having type 2 diabetes or prediabetes. And in fact, this resonates with the results of the PESA studies from Valentin Fuster in Madrid, where patients with pre-diabetes, right? Patients that don't even have an A1C that's getting them into the prediabetes already are having cardiovascular disease with PET MRs and advanced imaging. So obesity and type 2 diabetes and cardiovascular disease, this is all really the same space, the same pathology that we should be looking at. Now, one of the criticisms of this model is it really doesn't engage patients with type 1, insulinopenic, atypical gestational pancreatogenous, right, secondary diabetes, but it can. The difference is really in the stage 1, what the risk is. So the insulin resistance is more for the type 2, but the viral autoimmune fibrocalcinosis, in South Asia, that hit for a beta cell defect is still stage 1, the risk. You still have stage 2 prediabetes, stage 3 type 2 diabetes, or type 1 or pancreatogenous, and then stage 4 are the complications. So what's the point here? The point here is to intervene as early as possible to prevent the complications. That's what does the patient in. That's what's creating a lot of the morbidity and mortality. We then fold this together into a larger umbrella framework of cardiometabolic-based chronic disease. And here you can see in this insert, the way this is different from metabolic syndrome. Metabolic syndrome interrogates a patient at a single point in time, whereas the cardiometabolic-based chronic disease dynamic model looks at it over time with these different stages, again, exposing an opportunity early to intervene. And here you can see this double paper in JACC that we wrote a few years ago, where you can see abnormal adiposity and dysglycemia intersect at insulin resistance. And then the arrow goes into these early stages for cardiovascular disease. Not all cardiovascular disease has metabolic drivers, but atrial fibrillation, atherosclerosis, and heart failure have those metabolic drivers, hence cardiometabolic. So we approach these not just with pharmacotherapy, but with what we term lifestyle medicine, which is the non-pharmacologic, non-procedural management of chronic disease. And I've spent some time over the last few years putting together some books on this to try to advance and formalize this nascent space of lifestyle medicine, where rather than saying eat less and exercise more, you actually have strategy, which is codified, and tactics, a tactical plan to actually do this by integrating with society, with your municipality, with the village, with state, federal. You get legislation, you address structural and social determinants of health. Within the lifestyle medicine targets, you have nutrition, and now we're going to focus on that inpatient nutrition component. If you look at medical nutrition therapy on prediabetes, how many consults do you get for prediabetes in the hospital? Well, it turns out that as patients are being admitted to the CCU and they have obesity, which you could even term as severe obesity in terms of the risk for complications, and they have an A1C that's abnormal, you may get consulted now in a more enlightened type of atmosphere because you want to prevent another CCU admission and another CCU admission. And it turns out that with medical nutrition therapy and with the dietitian involved, you can see improvement in a lot of these metrics. Here are some systematic reviews and meta-analyses. Same thing, once a patient actually has type 2 diabetes, now they're at higher risk of progressing to stage 4 with complications. And we're all familiar with the basic principles of type 2 diabetes care. Here's the problem with the evidence base in the inpatient setting. It suffers the error of extrapolation, right? So when you write guidelines, you want to have original data that really addresses PICO questions that really applies to your population. But unfortunately, a lot of these non-guideline casual position papers, they suffer this error of extrapolation. They'll say, well, it was good enough for the outpatient setting. This is probably what we should be doing in the hospital. And there's really no evidence to support that. The objectives are different. It's not to preventing migration to stage 4 complications in the hospital. It's to prevent that in-hospital mortality, morbidity. But I would also say that there should be some continuity of care to the outpatient setting. That should be part of the consult. And if you're looking for a term, that's called defragmentation of care, a huge problem that we have not addressed in healthcare. To defragment, how many times you have a patient, they go to the hospital, different team sees them, puts them on different medicine, right? They're stripped off all of their oral medicine or non-insulin medicines. They're put on insulin in the hospital and then discharged on insulin or discharged on a sulfonylurea, discharged on something completely different than the way you've been managing them, or even just the behavioral medicine tactic used by the resident who doesn't even know your patient is imparting on your patient. And now they have different ideas about eating and physical activity. That fragmented care needs to be addressed. Gestational diabetes also really doesn't have a formalism for nutritional care in the hospital. Again, extrapolating from the outpatient setting. And by the way, as you're listening to this talk, I want you to keep in the back of your mind, these are research gaps. These are the topics that you should be thinking about. These are the studies that we want to do, that we want to formulate to address and narrow and close some of these research gaps. Yes, there have been some studies on the Mediterranean diet in gestational diabetes and studies looking at various commercial fiber supplements in the hospital for gestational diabetes, but nothing that's truly compelling. Here, and I apologize for the font, this is a paper which is often cited quite a bit by Guillermo Umperez, looking at the care of medical nutrition therapy, hospitalized patients with diabetes. But as you read through the paper, again, a lot of extrapolated evidence and recommendations. Nothing that's going to be surprising. A lot of the recommendations are vanilla. You know, nothing's going to be edgy or say, well, I didn't really know that. You know, where's the study? This is extrapolated information. And you'll be hearing a talk a little bit later. Harris is going to be speaking on diabetes-specific nutrition formulas. So we're really not going to go into that, although to say that these formulas are used not only in the ICU, where you're familiar with them most of all, but also in the non-ICU setting. Now, there are some challenges, tactical challenges in managing nutrition and diabetes in the hospital. First is synchronization. So how many of you have been called because your patient's hypoglycemic, and what you find is that the tray is late. They got their insulin, the nurse rounds, gives the prandial insulin, and then not 30 minutes, not 45 minutes, an hour, 2 hours later, they're off to a procedure. They come back, the insulin is on board, they haven't eaten that meal, and it's an asynchronous delivery of the mealtime, the carbohydrate, and the insulin. So there are certain tactical things that can be done really at the nursing administration and hospital administration level. I will tell you that they are very difficult. We've had to contend with this at my own hospital at Mount Sinai. I know it's a shared challenge in a lot of other hospitals. But as champions, endocrinologists and healthcare professionals in the diabetes space and the nutrition space, it's really up to us to notify administration of this consistent problem, having snacks available, being able to manage the snack time insulin, make sure there's no stacking of the insulin, having written protocols, including nutrition education material that's on the tray. This is a slide looking at the nutrition specific the diabetes specific formulas that we'll hear about a little bit later. Now, there was some thought, here's where some of the newer evidence appeared. There was some thought that carb counting in the hospital would be of some use, right? That maybe we can avoid some of the postprandial hyperglycemia and some of the hypoglycemia by instituting a formalized carb counting. So kind of easy. You have food service, coordinate with the dietitians, and they can count up the carbs that are on the tray. The nurses will have a preset equation, right? So not only the rule 1700 or 1800 or 1300, whichever your favorite rule is, but also the prandial insulin, the correction, that dose is delivered. So in this study, they looked at, there was actually no difference in the fixed dosing that you would write, 5 units of rapid acting insulin, ACTID, versus a carb counting methodology. To some extent, that's reassuring that we're not really doing it wrong, and that we really don't need to embark on the carb counting type of approach. Though on the right side, you can see in this study, which was done a few years later at the Mayo, did show that there were some benefits, but benefits that were more in the patient satisfaction space. There were some improved blood glucose levels, but this isn't translating into outcomes. The reason they did this at Mayo was to address some of the system failures, which I just described. Now, this was interesting data looking at chronotypes. Yesterday, we had some mention of the chronobiology and the different chronotypes. So you have younger people who stay up later and wake up later, kids. And then you have older people who may do the same thing. You have other people who wake up very early and go to bed early. And it turns out that depending on your chronotype, will determine or at least be associated with a higher glycemic excursion after a high glycemic index meal. And I thought this was pretty interesting. I don't think it's ready for prime time. I don't think we're going to embed this in our protocols yet, but it is important and it is consistent observation. Nutrition education programs we discussed, this needs to be formalized. There is some evidence base in different settings where it works, and let me conclude. What I'm going to do is, in this conclusion, focus on research, knowledge, and practice gaps. Research gaps are questions without answers. Knowledge gaps are answers without awareness. And practice gaps, awareness without action. This is the essence of our problem in healthcare now in dealing with chronic diseases. You're all familiar with the statistics and the epidemiology of how many people have multiple chronic diseases. So the DBCD model identifies more patients that would benefit from inpatient medical nutrition therapy. The research gaps are wide, and we do need more systematic reviews. We need more trials. We need active comparator groups and intervention groups with comprehensive medical nutrition therapy, actually inpatient physical activity and rehab, not just focusing on the dietetics. The knowledge gaps, we need better educational programs, particularly for glycemic index and healthy eating, and the practice gaps, as I mentioned, with formal involvement of these diabetes teams, wearable technologies, validated use of the diabetes-specific formulas. We need to transform hospital infrastructure. We need to defragment care, and we need to have an AI-enabled electronic health record that incorporates all this. Thank you.
Thank you so much for a very interesting talk.